PEGASUS-TIMI 54 was designed to investigate the hypothesis that patients with prior myocardial infarction were at long-term risk of atherothrombotic events, and that the addition of ticagrelor to aspirin would reduce that risk. And investigated two doses of ticagrelor, the 90 milligram dose that was studied in the PLATO trial in acute coronary syndrome, and a lower 60 milligram dose that was felt might be better tolerated as long-term secondary prevention. In PEGASUS-TIMI 54, ticagrelor reduced the rate of the composite endpoint of cardiovascular death, myocardial infarction, and stroke. And I think many people think of these therapies as reducing myocardial infarction or stent-related events. We actually found that there was consistent reductions in all of the components of the primary endpoint, including all stroke and ischemic stroke. And so in this analysis, we looked at stroke, particularly with the 60 milligram dose that's approved for this population. We found that stroke occurred in this population at a rate of about 0.4% per year, and that the drug significantly reduced all strokes, driven by a reduction in ischemic stroke with no counterbalancing increase in hemorrhagic stroke. In addition, we looked at the types of strokes, how bad were the strokes, and we found that ticagrelor significantly reduced moderate to severely disabling or fatal strokes relative to placebo. Many people think of long-term antiplatelets with aspirin and ticagrelor as to protect from recurrent myocardial infarction alone or stent-related events. I think these data really help to show that this population is first at long-term risk of atherothrombotic events, not stent-related events, but de novo events in the brain, in the heart as ST elevation MI, even as limb events we showed in a PAD population. So the population's at risk. And I think when we talk to patients about the potential benefits of taking long-term ticagrelor for secondary prevention, we should not only talk about the coronary events and cardiovascular death, but also ischemic stroke, which is one of the most feared outcomes for patients because of the disability and morbidity. Long-term ticagrelor, it's a potent P2Y12 inhibitor. It's not a thienopyridine. It has some different mechanisms of action. It's generally well tolerated, but because it has a different mechanism of action, there are some different adverse events. Early on after initiation, particularly we usually would initiate in the ACS setting, patients can have dyspnea, and that dyspnea is probably related to an increase in adenosine exposure, which may also have beneficial effects. The exact mechanism isn't known, but that's very unusual to develop that after long-term exposure, after someone's been on it for at least a year. The probably most likely adverse effect of any potent antithrombotic is bleeding, and patients are likely to have more either nuisance bleeding like bruising or bloody noses or major bleeding as well. I think it's important to note that there was no excess in intracranial bleeding, hemorrhagic stroke, or fatal bleeding overall, and so that while there is more bleeding, it is generally not of those types that tend to worry us most. I think that these data help to underscore that the patients with prior myocardial infarction are different than those that are undergoing stenting for stable coronary disease, and that prior MI really identifies an underlying risk, an underlying disease state associated with long-term risk. And we have to begin thinking about these patients as at risk over the long term, and they need intensive secondary prevention. And when we talk about the risks and benefits of therapies, it's not about the stent anymore in prior MI patients. It's really about new events anywhere in the vasculature, and we need to start thinking about it in that way with our patients.